Good morning, everyone. We have an IC on ocular imaging. The first topic is on the first click, the basics of good imaging and core modalities. Why is imaging important? It's a language of modern ophthalmology. It is involved in diagnosis, documentation, decision making, and also you can use those images that you capture for your publication and presentation as well. So for the rest of the presentation, I want you to remember the word prism. So what is prism? So P stands for positioning, R for resolution, I for illumination, S for stability, and M for modality. So if you have these 5 words in mind, whenever you capture an image and you adhere to it, you can definitely get good images. So why position matters? So in the first image on the left, you can see the patient is looking nasally, and hence the area that we wanted to photograph has not come clearly in the picture. So when the patient is given a fixation light and asked to look straight, that is when you can capture a very good image with good illumination. So positioning definitely matters. And also something further in positioning is framing. So whenever you are going to capture an image, you should have the frame in mind. So yeah, you are a photographer, you are capturing the entire fundus, but which area of the fundus do you actually want to focus on? Which area are you going to later use for your publication, or some pathology is there that you want to detect? So in this case, we wanted to detect what is on the disc. So hence that was made sure that that area is brought into entire focus and clicked. So this is one of the most important skill of a clinical photographer. So why is resolution important? So resolution means you have to bring the subject you are interested in into focus. In the first image on the left, the persistent pupillary membrane is brought into focus. You can see how the slit lamp can be moved in front and back to vary your focal point. So that is how you click really good slit lamp images. In the second one, you can see the lens zonules shown beautifully. These images were clicked by Dr. Samir, one of our speaker today. The last image is actually a beautiful image showing a silicon oil bubble being pulled down because of the denser PFCl bubble. So it is literally like a parachute in your AC. So the denser PFCl is pushing or is pulling the silicon oil bubble down, giving it such an appearance. And you can see the edges clear because the focus was there. So these kind of simple tricks, if you focus exactly on your subject edge of your subject, you will get really good images. This is another case of Axenfeld-Rieger syndrome in which multiple imaging modalities were used, slit lamp imaging techniques like transillumination, gonioscopic imaging, and even taking the peripheral anterior synechiae that is shown in the angles. So different aspects of the disease are brought out by different imaging techniques. So the next I stands for illumination. So light. So the light has to be adjusted. Too much light and too less light is a problem for us. So you have to decide in which pathology you want a highly exposed image or a less exposed image. In the first image, it's basically a cilioretinal artery sparing CRAO. So you can see because the exposure setting and the flash was set a bit high, the retina in the posterior pole is appearing a bit bleached out. In the second image on the top, you can see it's an optic disc pit maculopathy. So you can see the maculopathy border delineated clearly, whereas the pit is not actually visible. You can see a small notch there, but the depth of the pit is not seen because the disc was overexposed. So in the third image on the bottom, you can see the focus was on the disc. We wanted a good image of the disc, hence the flash setting and the exposure was kept down. So the surrounding retina may appear dull. That doesn't matter because the focus is on the disc. And you can see how beautifully the disc structures and the coloboma is captured. So this is why illumination is one of the most important modality to be adjusted. So machine wise also your images can vary. So if an Oguchi patient or patient with an Oguchi disease, you are try to capture in an Optos California, in a Claris 700 or in AIDAN, this is how the different appearances can be. So you have to decide like what modality you have. Next is if you have many different modalities, which one do you want to capture and why? So Optos California, you may want to do capture it to get the more wider field of view. Whereas the image will look really beautiful in AIDAN because of the imaging CSLO based technology it has. So you have to decide. So when you are having at your disposal many machines, you decide what you want to do. Stability. Both the patient and the clinician, the doctor has to be stable. So when the patient moves the eye, he left, right, or up, down, you will not get a good image. It will be defocused, blurred, which is as you see on your left. On your right, you can see a well balanced, stable image, which is showing the edge of the IOL clearly brought into focus. So in OCT also, these motion artifacts will be introduced when the patient moves the eye. So you can see the motion artifact and even the blink artifact. So you have to have an open eye with a stable fixation to get good images. So in prism, S for stability. M is modality. So in modality, there are different kind of modality that you can use for the same pathology. So if a patient is, this is a case of Goldman-Favre. So we have used fundus montage to show how the actual RP atrophy and the flex kind of lesions are seen around the arcades. And when you take the same image in autofluorescence, you can see the autofluorescent small flex particles in the mid-peripheral region, and also the atrophic RP is shown as black because they were hypo-autofluorescent areas. Now when you look at the multimodal image, multicolor imaging, so what you can see is the central part is showing an orangish hue. So that means there is a thinning there. So even without OCT, like you can see the OCT image below, which shows a thinned out fovea. So even without OCT, you get an indirect picture of a thinned out retina there. So the OCT shows a massive foveosis with central foveal thinning. This is another case of adult onset foveomacular vitelliform dystrophy. You can see a yellow whitish substance at the posterior pole over the macula, which when subjected to autofluorescence will show hyperautofluorescence. This vitelliform particles have the property of autofluorescence because it has a lot of lipofuscin pigments. Also, this is another case. So this is a case of pigmented paravenous retinochoroidal atrophy. So you have to decide what kind of an image you want. If you have both kind of modalities, like AIDON gives a duller, more bland image, whereas Claris will have a lot of orangish hues. So even though actually in PPRCA you get a lot of atrophic areas, those areas are more delineated, and maybe you can say more, you can say it is more whitish in AIDON. But if you for appreciating the color of the normal retina, the Claris looks better. So you have to decide and what you're going to use it for. Are you going to publish it, or is it just for documentation? So decision making. Why is decision making important? So modality helps you in making your valuable clinical decisions. So this is a case of CSVR. Patient had multiple pockets of fluids with PED. When patient underwent FFA, there were some areas which showed leak. So when the patient was subjected to OCT through those areas of leak, you can see the PEDs that have popped up. So that is where you will want to do a focal laser to seal those leaks. So if you combine all these different modalities together, you can give a better treatment for the patient as well. In this patient, patient is having an RNFL defect, which is photographed clearly with a fundus photo and a red-free image. So this is an interesting case of a subretinal PFCL bubble, which is migrating over time. So serial fundus photos, if you have, only then you can see how much it is shifting. 6 minutes rakada. So you can see post-op day 2 months, the PFCL bubble is above the arcade, and slowly after 4 months, it has shifted down. You can appreciate it by looking at the vessel and the distance of the lower margin of the bubble. This is a patient before PRP, panretinal photocoagulation, and 3 months after. 3 months after, the vessels are still proliferating. The FVP is increasing in size, showing that your PRP was inadequate and you will need to add more laser. So unless you have serial photographs, you are not able to say how the patient was earlier and how the patient is now. So serial photographs are important in these cases. So if you can understand your anatomy well, you can see this is a simple case of a YAG capsulotomy. Post SOR capsulotomy was done using a cutter. So you can take a creative image like this, and you can see it is like a spider that is hanging down. So you can even take creative images if you know the exact anatomy of what is happening. This is another case of limbal dermoid, which you can see we have taken clinical photograph, and you can see the dermoid infiltrating into the corneal substance, which is taken with ASOCT. Another case of patient who developed foveolitis and hemorrhages was subjected to FFA, which showed leak, and then OCT also showed a lesion at the fovea. Then on retrospect, patient was found to have an undiagnosed dengue fever. So imaging helps you, investigative imaging helps you in sometimes diagnosing undetected diseases as well. This is one new term. I want to end my presentation with this term called multidisciplinary imaging. You can combine ocular imaging, systemic imaging, and investigative imaging in your clinics to get the best out of your imaging capabilities and to treat the patient the best, and also to use them for publication. I will just show a few examples. This patient had preeclampsia who had a bilateral serous RD and also pedal edema before her delivery, during her pregnancy. Post delivery, everything subsided. So you can see how this documentation helped in getting this publication done. So this is another case of unilateral neurocysticercosis, which was published in Neurology journal. So you can see the how the fundus image, the B scan image, and neuroimaging to show the cranial lesions are also shown. This is another simple image. A small tick is there on the lid. This we must have seen day in and day out in our clinics. So how it is being removed, where it is has to be caught at the mouthpiece and removed. And on the right you can see a photomicrograph captured on a microscope by a microbiologist. So when you combine this, you get a good publication again. So this is another case of bilateral multifocal choroidal metastasis, which after multiple investigative modalities, the patient was found to have non-small cell lung carcinoma. So in this, we have combined histopath images, CT images, X-rays, and ocular imaging findings. So this is another case. Sutural cataract is not so common in neurofibromatosis. Even then it got published because the way the images were photographed. We are showing the lesion nodules, all the cutaneous lesions. So when you have good imaging and you combine it together, like that's the term multidisciplinary imaging. So I want you to take that message home. So we have a very interesting IC plan today. My colleagues will be discussing peering through the front window into the depths, unmasking the hidden, and from clinic and to citation, basically ending with publication and presentations. So from this talk, I want you to take home the message PRISM. P for positioning, R for resolution, I for illumination, S for stability, and M for modality. Thank you. I would like to call upon my dear friend Dr. Prasanna. He is a research head and a glaucoma specialist at Mahatma Hospital, Trichy. Thank you.
Thank you, Dr. Atul, for sharing how even a simple scenario I just joined at the end, how it can be actually made into an image or if not a publication. And it feels very heartwarming to be among like-minded collaborators like Samir, Shishir sir. I think even I would like to acknowledge Prithvi as well. Yeah, is the slides ready? Yeah, perfect. Yeah. So thank you, Atul, once again. I'm going to share a similar take from my good friend Dr. Atul. Anterior segment imaging, if I can have a laser pointer also. Yeah, Samir, pointer. Yeah. So how I started doing is, I always believed in videos. Videos gave more scope, and I used the simple adapter which Dr. John Davis taught me, and I started using iPhone to take all anterior segment images. And even at one point in time, we also were one of the first to record the AIOC PA. If you go to YouTube and see, you won't find much videos on AIOC PA. See how the bubbles come in from below. So there are a lot of things, which are still not done, not documented. Even the photo disruption, we were the first to document and publish on photo disruption. You can see this is the photo disruption, how it looks in the slow motion. So anterior segment imaging starts with slit lamp. And of course, I can see my senior Dr. Vishnu sir, who used to tell a lot about this, but I didn't do much when I was his junior in MGM. We learned these things a bit late. And IFEMA, like how I managed a case of IFEMA post-suture gap. So I make it a point as an SOP to document everything with anterior segment imaging, an anterior fibrinous membrane, like how we are breaking it. So we never know which will become a good image. You can see I'm opening up the fibrin membrane, and then from there you can take whatever photos you want. So this is the before the YAG and this is after the YAG. So these are the things, I tell my residents and PGs, try to do a YAG cap, YAG PA with videography, because each case would be different where you can have more imaging. And this is a alignment of gonioscopy that we have at our center, where we make sure it's like a geometrical paradox. And these are some of the other videos of mine. Any imaging that we do, we make sure it's part of multimodal. Anterior segment along with the bleb of the same patient, we make sure we assorted multimodal imaging Another one that I told is the POTO application, which I very fondly use in the Apple system along with the iPhone. You can see the gonio of all the four angles assorted just in your hands itself, and you get the geometrical paradox, and you can go for a publication as well, because this is how it looks in reality, right? And follow-up images also, if you see a simple foreign body, if you want to follow it up, aligning it together and seeing how the epithelialization or the stromalization happens in day 1, day 2 and what not. So again, this is another armamentarium anterion where we started using it for multiple things, and we had a breakthrough in MIGS as well, adherent glaucoma, ICL vaulting, and we also did a case for a granulomatous uveitis where slit lamp, gonioscopy, specular, ASOCT, and then the Schlemm imaging. And you'd be like able to see that you can even quantify each KP, and we actually published it in the Indian Journal of Ophthalmology. Again, this is another case where we were able to, with the Schlemm imaging technology, we were able to completely dissect the densitometry of the congenital lamellar cataract, and as you can see here, and a lot of things that you do with anti-segment imaging can be got out as publication. All these publications that I am showing you are all mine, and all of them are PubMed indexed. One of the patients on phenytoin ended up with angle closure, and this is post-YAG PA, pre and post-YAG PA, where the angles are opening up, and then you can see that the PA is done, and then the IFEMA is there, and the angles open up. Patient also has hypermetropic traits. Another thing which I just showed previously, the foreign body through the looking glass. I tell my residents, even if it's a simple case, see how it happens, see how it behaves optically, see how the epithelial, the stromal thing goes, fungal ulcer, you can document those. Especially we did extensive work during the COVID time with multimodal imaging and Schlemm imaging, as you can see in these images. And these are some of the other images which we started collecting. As you can see, even the nevus, multimodally, staphylomas, you can collect, as Dr. Atul was also telling. You don't need to go about a rare scenario. What best can I document even in a scenario that is there in my OPD, in my scenario? A simple case where there was a PC rent, vitreous coming into the AC. See, my dear friends, it's a very good section. Anterion gives you this good section, ASOCT. I mean, you can have so many things. Even a simple striate keratopathy for that matter. You can go back tomorrow. This was published on the first page of IGO case reports when IGO case reports came after the editorial. How a simple SK started to heal. We just thought, why not we go back to basics, and we labeled it as optical blooming. That was first published by us in literature, the concept of optical blooming and the iritis fumes, how it settles down post-op day 1, day 2, post SICS by a trainee. And many things. Even you can see a simple prosthesis. Can you see the serrations here in anterior-segment imaging? How the prosthesis can actually settle on the anterior ocular surface. These are the serrations that you get with anterior-segment, not with Schlemm imaging. Thin walled cystic mitomycin C bleb, which is like a time bomb, very well documented again. All of these are extensively published. Iris Bombay itself gives you lot of data. During PG, this was one of the conditions which was very confusing for me. Why does this happen the way it happens? A pseudobleb, one of the SACS patients where we had a pseudobleb in the temporal side, and you can see the septae and loci. Each dissection of it in extensive visualization dissection can be done. The septae and loci, you can see that this is where the wound was going in and the conjunctiva was pulling in. This was the bleb, the two septae on the other side. Another patient with NSAID induced corneal stromolysis, anterior subluxation in a microspirophakic patient. Just before taking the patient to OT, I told we'll quickly image the patient and then take the patient to the OR. You can see how much the anterior lens is almost close, or if not touching the cornea. Again, Wolfen-Schlieff's clothing, a patient with cough syrup induced issue, bilateral pupillary block induced angle closure, again extensively published, and the patient did have some amount of hypermetropic traits as well. Last but not the least, this was another case during COVID-19 where when ours is a training institute, and we do have a lot of flap related tear or flap related complications by the fellows that we have. So you can see some of the flaps are all iatrogenically entered with the fistula, and we were using a Gore-Tex to actually make sure to cover that particular area because the donor tissue was not available, and that was rejected and the fistula was there. But see what we did. Extensively, we followed up the patient with anterior segment imaging, how the fistula is healing, how it is closing, and you can see the same fistula after 3 months, the fibrosis or the cicatrization that is happening. As a glaucomatologist, I am happy that this from here it's going to here because the wound is actually closing, and I don't need to worry that the fistula will break. On anterior segment, you can see now here you can see the white color. Here you can, from here to here, it is actually going in for fibrosis. So it's very important for you clinically. And this was a recent paper, a breakthrough paper last year, where we published a lot of name signs. A Y sign in KDB, a remnant of tissue in band. Suchagat had a bird beak, all were, like you can see, it's all name signs, bird beak configuration. And iStent and iStent Inject had a backscatter. It's a very nice time to be here. These are some of my images. I won close to 50 plus images in AACRS 2022, AACRS 2023. These are all my award winning images. AACRS 2024, IRSA 2021, 2022 and 3, 2022 in TNOA. Again you can see 2023, and these are my 3 cover images: IJO, Academy, Kerala, as well as case reports, TNOA. I'm just showing these images. I'm not going into the detail. If you are seeing these images, if any one of your images you like it, always get back to me. I will always be able to teach you how I made these images, along with one of the cover page images on the AIOS 2023 program book was made by myself. So you can catch me here in Instagram. I would be able to mentor you one-on-one for any one of the images that I just showed you. Thank you, Atul, for this opportunity once again.
Thank you, Prasanna, for this wonderful talk. Now I invite Dr. Shishir for the posterior segment diseases. Dr. Shishir Varghese is a vitreoretina consultant at Amita Eye Care.
So thank you, Dr. Atul, once again for this opportunity. Always a lot to learn from you and Dr. Prasanna and all those speakers also here today. So I'll be talking on into the depths posterior segment imaging. So let's deep dive into posterior segment now. So as you know, the retinal imaging is the backbone of the retina practice. And now there is a shift. It's not just fundus photography anymore. There are multimodal imaging. It's a shift to multimodal imaging now. Along with fundus photography, you also need to do the OCT, OCT angiography, etc. And so it's not like you're imaging the retina, you're also interrogating the retina, because which involves a complete detailed examination. So let's look at some of, now this multimodal imaging is exhaustive actually. There's a lot of things to discuss. Fundus photography, there is multicolor imaging, there is shortwave autofluorescence, green, infrared imaging, retro mode, which is one of the features of the NIDEC Mirante machine, the OCT angiography, which are all non-invasive modalities. And then you have the invasive modalities, which is the FFA and the ICG angiography. So let's look at there are 2 types of fundus photography. One is the true color fundus photography, which is given by the EDON, the Claris, what Dr. Atul just showed. And then you have the pseudo color imaging, which is red, green and blue, which are lasers, which are contrasting. And then it gives you this kind of a pseudo color kind of image, which is seen with the Mirante, which you see on the left side. So if you go for the true color image, this is an image from EDON, and you can see how beautifully the true color image looks like. Gives a realistic appearance of the retina in a true color, whereas in a pseudo color, this is how it gives you the image. So this is a patient with a subhyaloid hemorrhage, and this is pre-treatment and post-treatment. So always good to take a post-treatment picture also, just to show the patient that the treatment which you have done for this patient. So this is how the pseudo color looks like. And then you can also, the option in Mirante is there, you can tweak up the imaging a little bit. So this is a contrast enhanced image. This is the pseudo color image, what you see on the left, and then you enhance the contrast a bit, and then you can get this kind of a little more detailed appearance of a patient with a retinal detachment with PVR. So there are other options also. You have the color image, then you have the red free, then you have the green free, then you have the blue free images. So this is a patient with a dislocated lens, and you can see it contrasts a little more better when you have this black and white kind of a red free image which you get. So also in the red free images, you can also get this SLE retinopathy with a NV into the vitreous cavity, and then you can see post laser treatment how the regression of the NV is there. It is detailed much better in the red free image as compared to a color image. So then you have option in Heidelberg also, you have the option of this multicolor imaging, which is seen. It's not the Contrast per se is not so great, but then multicolor is of use, especially when you don't have a proper color fundus photography. Next, let's go to fundus autofluorescence. Extremely important in cases of dystrophies, patients with CSR. So it's a patient with a cone dystrophy. So when you have cone dystrophy, always for publication purposes as well as to follow up the patient, you need to have this fundus autofluorescence image where you can see this kind of like a bullseye maculopathy there. And then you look at the OCT also, you can see the photoreceptor atrophy, what you see there. So another patient, now this is the optos imaging, what you see. Not clearly very made out that this is a patient with CSCR, and then you get the fundus autofluorescence. You can see nicely how the teardrop sign as well as the waterfall sign you can see in a patient with chronic CSR can be made out with the autofluorescence. So you have the blue and you have the green. The green is advantageous, especially when the patient has a cataract, as the cataract tends to absorb the blue light. So this is the OCT of the chronic CSCR patient. So now next is infrared imaging. Now this patient came in, it looks normal. This fundus photo looks normal. This autofluorescence looks normal. This is a red free which looks normal. This is a green free which looks normal. Now, but when you do the infrared, you can see there is some patch there at the macula there. I don't know what exactly that is, but then when you do the OCT, you know that it's a choroidal nevus. So that's how where the importance of infrared imaging is, especially for these nevus and these lesions, what you see neurofibromatosis. Infrared imaging is of extremely useful, as well as to show the patient and then to counsel. So this is another patient with, looks a normal fundus. This was actually a patient with neurofibromatosis, but when you do the infrared imaging, you can see these choroidal hyperreflective lesions, what you see, the neurofibromatosis nodules. So this is another feature of the Mirante, which is only there in the Mirante, which is the retro mode imaging. So what is retro mode imaging is the light gets scattered from the choroid, and then you get these three-dimensional pictures, what you see. So this is a patient with choroidal folds, what you see here, all these striations, what you see in a little more 3D pattern. These are patients with pigment epithelial detachment, which are seen again like a 3D, like the craters of a moon, what you see with the retro mode imaging. So this is another patient with drusen, which you see on the fundus photography, but when you do the retro mode imaging, you get it more like a 3D kind of a lesion, what you see. So OCT, as we all know, extremely important in retina practice. I mean, if you see sometimes even a normal fundus, before your cataract surgery, before counseling, you need to do your OCT, and you can get multiple images, good images and ideas with your OCT, as well as to treat the patient, you need to have a OCT too. Now let's dive into OCT angiography. So this was a patient with who came with complaints of decreased vision. So I don't know whether this was a CSCR or whether this was a CNV. So I did an OCT angiography, and you can see beautifully this nice medusa-like network, what you see on the OCT angiography in the deep layer. So that's where the angiography is important. So this was another patient with a lot of drusen, and this is the autofluorescence of the drusen, what you see, this hyperspectral-like autofluorescence. And when you do the OCT, you see that there is some amount of subretinal fluid, what you see there. So I don't know whether this is a CNV or whether this is a dry AMD. So when I do the OCT angiography, I don't see any sort of a network there, and then this patient was just put on follow-up. So similarly, you also have the option of a wide field OCT angiography. So we have the Optopol Revo, which has got the option of a wide field OCT angiography. So this is a patient with branch retinal vein occlusion, and you can see the OCT angiography wide field gives a beautiful area of non-flow, what you see superiorly to the area of the branch vein occlusion. So FFA, another very good imaging modality, but invasive. So you can pick up PDRs, you can do your focal laser for your CSCRs, what Dr. Atul showed in the beginning. So this is another where there is a polypoidal choroidal vasculopathy. That's where you require your ICG, and that's where I primarily use my ICG for patients with PCV. You can see the polyps, which are seen very beautifully on the indocyanine green angiography. So this was another patient. Now this patient had like a wet age-related degeneration. So I was not very sure what I was dealing with here, whether it was a type 1 or whether it was a type 2 or a type 3. And that's where my FFA and ICG has helped me. So you can see beautifully this vessel dipping into the choroid there, and it's retinochoroidal anastomosis. So this is like a type 3 MNV. Here again on the choroidal, on the ICG, you can see the vessel dipping and into the choroid, and you can see this beautiful network, what you see on the ICG there. So this was a type 3 MNV, again difficult to treat. So this is where your multimodal imaging with the FFA and ICG helps you. Now B-scan, again extremely important, not mentioned, but very good images you can get with the B-scan, especially when there is no view to the media. So this is how my OPD setup looks like. Now in our practice, it's extremely difficult to convince the patient what the disease you are having. So I've got my the imaging modality software connected to the TV, as well as I've got my anterior segment connected to this TV there. So the patient can have a look in real time what exactly, they're dealing with, what I can actually show them what exactly the problem they are having. So this is my setup there. And like I said, B-scan was one of my first image publications, which I did in ophthalmology retina there. This was a patient with a PFV, and you can see this beautiful B-scan image. So similarly, I've had multiple, like very big fan of imaging, so I've got multiple publications with imaging. The same contrast enhanced imaging I have used, and multiple other images I have published in ophthalmology retina as well. So it is always important for multimodal imaging. So this was a patient which had a torpedo maculopathy as well as a CSER. But the mistake I made here was I did not do an FFA and ICG. I tried for a publication, but all the journals rejected it because you did not do an FFA and ICG. So we don't know where the fluid has come from, whether it's from the torpedo or whether it's from the CSR. So always complete your cases by doing the complete imaging modality. So to conclude, multimodal imaging extremely important. You can tweak your image by using either AI or the machine itself. So when indicated, always get an angiography, and you can try to convert your publication or get it to a cover image. And also sometimes intraoperative images are extremely good. You can get good intraoperative photography as well. Nucleus drop. This is like a donut-shaped nucleus. This is a aqueous IOL, and this is the PFCL bubbles, which are stained brilliant with brilliant blue-green dye. So, thank you.
Thank you, Dr. Shishir, for this wonderful talk on posterior segment diseases and imaging. Now I invite Dr. Rajshri. She is a UVA consultant at Arvind Eye Hospital, Madurai.
Thank you, Dr. Atul. A very good morning to one and all. So, uveitis is as such a very challenging field because the clinical pictures are not only very diverse, but they can also be very deceptive. So this is when multimodal imaging comes into role, where we can pick up subtle changes which we do not pick up in our clinical examination. So far we saw how the different imaging techniques could help us in establishing good photographs, and so here we'll be looking about how they help us in putting up a proper diagnosis and then to go about with the correct treatment. So first case is a 47-year-old female who came to us with defective vision since 6 months. Her vision in the right eye was 636, and she also gave a history of not completing ATT 11 years back. So this was her clinical picture. You can see that there are multiple small choroiditis lesions scattered all over the posterior pole. This is what we call the multifocal choroiditis with pigmented chorioretinal scars typically along the vessels. Now this is very typical clinical scenario of ocular TB. So systemically she should not have any reactivation of TB. Now one more sign which helped us in establishing the diagnosis was the OCT sign, which we call the contact sign, where you see increased reflectivity between the detached neurosensory retina and the underlying RP. Now this is a very classical sign of choroidal granuloma of ocular TB and called the contact sign. So the patient was started on ATT with oral steroids, and yeah, this is the post-treatment picture after 6 months of ATT. Now this patient is a 15-year-old child, known case of Behçet's, already on double immunosuppressant agent, methotrexate and MMF. Still, you can see there is activity. There's a white sterile infiltrate inferiorly. Now, we know that Behçet's is a systemic vasculitic disorder. So now we need to know the underlying burden of the disease before we go on to a next agent. So now this is when FFA comes into a role play. A normal looking fundus like this can come up like this in the FFA, where you can see diffuse capillary leakage. Now the capillary leaks on either side of the main vessels typically resemble a fern, and so that's why we call this a fern pattern leakage, and this tells us that the disease is pretty much active. So the child needed injection adalimumab, a newer biological, to suppress the inflammation. Now this is an 11-year-old female child who came to us with a lot of these small white pre-retinal aggregates. She gave a history of fever 1 week back. Now if you can see these white inflammatory aggregates, they just look like any other normal inflammatory deposits. But if we had started the child on steroids, it could have been disastrous because the OCT showed the rain cloud sign, where you see the hyperreflective lesion with the preretinal exudates in front of the lesion, and there is posterior shadowing obscuring the inner retinal layers. So here the rain is the preretinal aggregates and cloud is the back shadowing area. So now this is very characteristic of a fungal endophthalmitis. So PCR with molecular diagnostic showed that the fungus was Laceo-diplodate theobrome, and the child was started on IV amphotericin with oral voriconazole for over a month, and this is after complete resolution. Now this guy, he came to us with the very poor vision, 1/60 and 5/60. He was being treated elsewhere for vasculitis. Now if we see, overall we know that there is something wrong with the fundus. There's an yellowish hue, but we do not know what is going underneath. And he was extensively being treated with steroids for vasculitis. So this is the OCT image. Now if you can see, there are nodularity of the RPE with ISOS disruption, and there are punctate spots in the choroidal area. Now this is a very classical sign of ocular syphilis, a great masquerader. He came out to be positive for VDRL and TPHA. Was treated with penicillin. A week later, oral steroids were added, and his final visual acuity was 612 and 618. This was the before and after picture. So usually in ocular syphilis, periocular steroids are generally avoided, and oral steroids have to be started only after starting antisyphilitic treatment. Now this female, this is a classical case of serpiginous choroiditis. You can see that the inflammatory pattern looks like a serpentine way. Now if we want to know whether the lesion is active or is just a scar, a simple autofluorescence helps us in picking up the lesion. If you see, the borders are hyper-reflective, which means it is very much active, and the inner areas are scarred, which means they have been completely scarred, and the other eye also shows few lesions, but again autofluorescence has picked up that eye lesion again is completely scarred. So this patient will need immunosuppressants after ruling out infective etiology. Now this is a case of serpiginous like choroiditis, where patient was found to have TB. Again, if you see, the borders are hyperreflective, which means the disease is pretty much active. And this is a farmer who came to us with a trauma to the left eye with a date palm leaf while he was riding his tractor. Now he was being treated for nodular scleritis outside with oral steroids, but when you do a simple UBM, you can find out that this is the hypoechoic mass, which is suggestive of a scleral abscess with an intact scleral wall. So again, we did a drainage of the pus, and then we found out it was a rare dermataceous fungi called Medicopsis romroi. So we immediately stopped all the steroids, put him on antifungal, and then it never occurred back. Now this patient is a case of bilateral, like the patient came with pain in both eye associated with headache. Now she was being extensively evaluated outside for headache with neuroimaging. Now when you look at the patient as such in the slit lamp, it was just a white eye, but all we have to do is simply just avert the lower eyelid to look for pharyngeal congestion. Now pharyngeal congestion is a classical sign of posterior scleritis. All we need is a simple B scan to pick up the increased retinochoroidal thickness with the subtenon fluid with the classical T sign, and the posterior scleritis, all it needs is a course of oral steroids. And in the FFA you can see there's disc-leak and pulling wherever there is serious detachment. When you see a focal retinochoroiditis, and if you see this sign in OCT with a retinochoroidal lesion with an attached hyaloid, don't think twice, it is ocular toxoplasmosis. Treat them with Bactrim and azithromycin with oral steroids, it responds. This 41-year-old male came to us with these multiple large choroidal lesions. Now it may look like just any other choroidal granuloma, but when you look close, there are subtle pigmentary changes over it. Now that is a very ominous sign because it can be a metastatic lesion. FFA usually reveals early hypofluorescence followed by late hyperfluorescence with small pinpoint leaks. Now this is very classical of a metastatic lesion. So these are nothing but choroidal metastasis, and lung biopsy showed moderately differentiated squamous cell carcinoma. So this is how a simple imaging can extensively help us in getting into a diagnosis. This is a case of multiple subretinal infiltrates, and OCT will show this typical sub-RPE infiltrates, lumpy, bumpy choroid, thickening of RPE Brooks complex. Now, this is a very classical sign of ocular lymphoma, but the vitreous biopsy came out to be negative. So, what we did, we went ahead, referred the patient to a neurologist, and neuroimaging showed multiple enhancing lesions over the thalamus and the corpus callosum. The biopsy of those lesions came positive for immunohistochemistry BCL2, CD20. It was nothing but diffuse large B cell lymphoma. So, thank you so much. And I would also like to put a warm welcome to everybody. Kindly save these dates. We have the annual Uveitis Society of India conference hosting at Madurai this year. Thank you.
Thank you, Dr. Rajshri. Now we have our last speaker for the instruction course, the young dynamic Dr. Samir. He has an array of awards, publications to his name. He will now take us through. So now, till now, we have learned how to capture good images. Now he will tell us how to use those images to publish and to present in conferences, how you can edit them and how we can take it further. Over to you, Dr. Samir.
A very good morning to one and all. Since we have been taught by our previous speakers how to capture these beautiful anterior and posterior images. So now once we have captured all these images, what should we do with them? You have captured a very peculiar image. What is your next step? So you can use these particular images in various aspects, but before we move towards publishing them or utilizing them in a certain way, we should make sure that they are actually presentable by editing them. So if you see the image that has been captured here, it looks very raw. It looks as if you cannot use it anywhere. It captured using a phone through a slit lamp eyepiece, but by just simply cropping it, it comes out very well. And this is a lens coloboma. The patient had an underlying RRD, and this was a case of a Schwartz-Metsuo syndrome with the lens coloboma, which was published in Journal of French Ophthalmology. Then comes to Adobe Photoshop, which is a editing software which is usually used by professionals. So it allows you to edit in much more depth. For example, certain journals have certain requirements. Your image should be in a certain format, a TIFF or a JPG. It requires a certain resolution. For example, 300 dpi resolution should be there. So it allows you to tweak all those particular settings and gives you a good canvas. Now a lot of journals also use image publishing charges. For example, IGO has an image publishing charge for each and every image that you use. So for example, if you have 4 images you want to put in a photo essay or a case report, so you can make an image of 2 by 2 and Photoshop allows you to use those guides and edit this photo collage really well. Now this was a case of a young female who had unilateral glaucoma, and you can see it's very evident that she has bilateral nevus of phota in this image, and she was being treated like that for a very long time. One of my consultants, she gave me this case, a bilateral nevus of phota with bleb leak, underwent TRAV, had developed bleb leak. But if I looked very closely and I thought that there's something wrong in this. There is some reddish hue that you can see on her on the right side. So I edited a little. Okay, I enhanced the red hue in this and made it a little more evident. And if you compare both the images, the image on your right, the red hue looks much more prominent. So this was actually port wine stain. This was a case of phacomatosis schizophrenia, which is basically port wine nevus flammeus along with dermal melanocytosis, and he published this in IGO. Now if you see, this is several images taken using Heidelberg in several cases, and right now it doesn't make much sense, right? So this is a video taken from Dr. Prasanna's presentation. So you see how he edits them very beautifully in Photoshop itself. He traces all the different gazes on the center, the primary position, how he traces each and every vessel uh, over the other one, and you see at towards the end a beautiful montage comes up. So the advantage of Photoshop is that it allows you to edit in much more depth, although it requires a relatively steeper learning curve. How I learned was through various YouTube videos. Now very simple tools like Canva, they allow you to edit very, if your image requires very simple editing. A lot of times, the journal will require you to point out certain findings. So for example, if you see in this fundus image, I have put an arrow for the cotton wool spot. In the image on the right, the MRI, I have just pointed out the thickened nerve. So all these, very simple editing can be done using tools such as Canva. Now coming to AI, so this was an image of HFA which I had submitted for an original article in a journal. So the reviewer wanted me to swap the images, the right and left, they wanted me to change. Okay, so this was a single image. Now editing it again, exchanging it becomes a little cumbersome. So what I did was I just asked Chat GPT to just switch the right and the left eye, and if you see, it has done very beautifully without any errors. Now coming to how we can utilize these particular images, let's begin with the research articles. So you have several ways where you can use these images. You have ophthalmic images, photo essays, pictures and perspectives, and clinical correspondence. These are basically different names given to image publications with a little bit of variable write-up. For example, 100 words to 250 and so on. So why to publish these images as a resident? Probably these are very easy to begin with. You can finish them within a day. Just a 100-word write-up. It's much easier to do. Very minimum references, and they have a very quick response time. If you submit it in ophthalmology or eye, if they want to reject, they'll probably reject in 1 or 2 days itself. And a lot of journals are now prioritizing images over case reports. Not a lot of journals have segregated, a separate case report journal, and although they're still accepting images in their main journal. So this is a list of few journals who accept images, ophthalmology and its companion journals, CJO, JAMA Ophthalmology, EJO, then you have Journal of French Ophthalmology, NMJI, IGO case reports, and you have various state journals. So these are few of my image publications through the journey of my 5 years in ophthalmology. Now how you can make it publishable. So it's not necessary that it has to be very unique. It deserves, it adds a very significant value to the literature. It can be just a little creative. It can be of a very good quality, and probably you can just publish it. So if you see, this is a case which I had seen post-operative during my post-operative rounds. Just a posterior capsule opacification, but if you see it looks, the pattern is a little unique. It sort of resembles a crocodile chagrin that you see in the cornea. So I just gave it a name of crocodile chagrin PCO, and it got published. Similarly here, cobweb PCO, the PCO resembling a appearance of cobweb. Now if you see this case, this was a pre-existing PCR with posterior polar cataract. So posterior polar cataract is also called bullseye opacity, and if the sign that you see here is an ASOCT. This shows PC dehiscence. So this is called teardrop. So we just titled as teardrop in bull's eye. Now this is case, this is 360-degree KF ring in a case of Wilson's disease. Nothing very unique, just a good image, and just to make it interesting, what I did was I just compared it to the historical copper coin, and it got published in TNOA JOSR. So coming to the next aspect is the cover images. So there are several journals which accept cover images. The disadvantage of publishing cover images is that it is not citable. Okay, it does not have a DOI, so it does not carry much value as such. But anyway, if you have a good image, it's always good to have feature on a reputable journal. So ophthalmology, CJO, IGO, TNOA, JSR are the few journals which accept them. So the image should be of very high quality. It can be a very common entity. Here aesthetics matters. That particular awe factor matters a lot. Okay, so how to submit? So you can just mail the editor. So I has this following email address. Ophthalmology has that following email address. Just write a short title and along with the description, and you can just send it to them, and they reply very quickly. So this was something which I submitted very recently. This was a case which I saw in my retina prelims. Just a conjunctival cyst. I made a narrow slit. The cyst turned out to be very transilluminant, and I just captured it titled as conjunctival lantern, and within 2 hours I accepted this particular image. So this image, copper coin, the one which I had published, got accepted on the cover of TNOA JSR. Then another image of ectopia lentis got accepted on TNOA JSR, and this particular image of Goldman-Favre syndrome was submitted by our chief instructor, Dr. Atul. So coming to image competitions, there are several image competitions available: APO, APOS, VRSI, clinical case competition by IGMR, AOS, ASCRS, Image Bank, EVRS, Image Honor Award, state conferences, various, and even UC image competitions are there, including the cataract chitra competition. So the inaugural season of CCC, I got the first prize, which was among the several awards that I got for UC Con. So this was, I was in a peripheral center where there was no slit lamp camera, and I saw this particular case. This image was clicked using a phone through the slit lamp eyepiece. Shows a subluxated lens with the PXF material over the zonule. So if you see, the title that I gave was quite unique: pseudo-exfoliative blizzard, frosted zonules with phakic shiver, and the last line that if you read, the phacodonosis and the white pseudo-exfoliative material over the zonules give the appearance of a lens that is shivering in frosty conditions. So I was the runner-up winner for the APO APOS imaging competition. If you see that particular image on the very right, I clicked it using a 90D lens of a MLOP doing refraction in a cubicle, and I just portrayed, how the life of a patient is with a refractive error. The blur surrounding the lens shows without a refractive correction, and the clarity through the 90D lens shows how the quality of life for a patient can improve. So the journey through image competitions was prolonged. I submitted in several imaging competitions, but to a failure. And even in the APO competition, there were 10 submissions, out of which one got the prize. So coming to teaching and presentation, so if you want to show a resident, a person who has just joined, how gutte look like, so you can show them a case of Fuchs endothelial dystrophy, and the video that you see on the right is a case of an anterior lenticonus. So I'm just shifting the slit horizontally to show how the normal curvature looks like against the increased protrusion that you see in lenticonus. Now again, neovascularization of the iris and neovascularization of the angle seen on gonioscopy, and several images, pseudo-exfoliation, lamellar cataract, blood in Schlemm's canal, sutural cataract, ciliary processes, Flickton. Now coming to the last part of the presentation, which is book chapters. So you can it's very important to document and keep images, because sometime later in your career you might get an invite to write a book chapter, or probably a consultant might ask you to assist them writing a book chapter. So all these images, for example, this particular case of optic neuritis, just having that particular image allows you to add that image enhance your book chapter. So how do I take my photos? Majority of my photos are taken using smartphone camera. I usually disable the macro mode and increase the zoom. So I usually have an album in my phone titled as clinical photo. So whenever I see an interesting case, I just capture the image and add to that particular album. So thank you.
Thank you, Dr. Sami, for this wonderful talk. So I hope you had a wonderful journey through ophthalmic imaging. We will take questions for 5 minutes. Does the audience have any questions to ask the speakers? So the images can be of two types. So one is you see a very rare condition which mandates photography. So you are seeing a case once in a week, or like one case you have seen that type of a case in a long time that you're seeing for the first time, definitely photograph it. Or if you see a typical case but you are seeing a typical finding, even then also you can photograph. But routine imaging may be difficult in a very busy OPD setting. So if you have access to imaging or someone else is there to photograph, definitely you can. At our center we do fundus photography for almost all cases. So we have a lot of those fundus documented. So when you want to go back and look at it also, you have that. So but in a busy practice, you can decide based on the novelty. Pardon, sir?
So you would have thousands of images in your database.
Yes, sir.
So how would you retrieve it? Means do you label images or you classify them or?
Yes, sir. So the images are classified based on diagnosis. So and also the clinician or the doctor who has seen the patient in the OPD would have noted down the patient details. So later on, when at the back end also, we can go and retrieve those images from the fundus camera or from the cloud server. In the Heidelberg Spectralis also, we save cases based on diagnosis as well. So we can search the patient details based on diagnosis also.
But those Heidelberg has drop-down boxes or you write diagnosis? Because if you use drop-down boxes, search becomes easier and more uniform. So does Heidelberg have drop-down boxes?
Yes, sir. So when you enter the patient data at the time of capture itself, because the patient is coming from the clinic, already there will be a provisional diagnosis entered by the doctor. So the technician who is capturing the OCT would enter the diagnosis in the patient data itself, along with the demographics.
You have not understood my question.
Sir.
My question is when the technician enters the data in Heidelberg machine,
yes, sir,
demographics, are these diagnoses in drop-down boxes of Heidelberg
so
diagnosis or have to be?
So once you enter, yes, sir, that's a good question. So once you enter a free text, it gets converted into a drop-down list. So once you enter CSER once, later on you can get the CSER from the drop-down list. So for every patient, you just have to click on the drop-down after that. Yes.
Yeah, I think Prasanna also mentioned and Sameer has also mentioned, like Prasanna told, keep on recording videos.
Yes.
You know what good picture you are going to get and just you can take that picture and don't miss like what is going to happen even if you are operating, your video is always on, not like that. You particularly put your video on specific cases. If your video is always on, you never know what is going to happen, which will be very, very important.
Definitely, sir.
And same way, whatever you get it, just record it, make an album, and keep on storing in that. Like Sameer was also telling, like I save in my phone, make separate album. I know where and when it can be used.
Yes.
So I think that is the best way to store your all the images, and whatever you get it, make it so. Otherwise, later on you will finding where they are, and you may not get it again.
Yes, sir. Definitely.
That's the best way to document, and of course, and don't forget in publishing. Whenever you can do, and this gives you further boost to do better work.
Yes.
Better for the society also.
Yes, sir, definitely.
And excellent presentation. I must congratulate Atul.
Thank you, sir.
And you have done a wonderful job.
Thank you, sir. Thank you. Thank you. Any more questions? So we'll wind up for the day. Thank you all for coming and attending this IC. Thank you. Rajesh.